And I'll just read her little bio that we sent to, and then she can fill it out better than that when she talks. But if you saw our meeting announcement, you've seen this, but many of you may not have. Kristin Dawson earned her medical degree at the University of Kentucky College of Medicine, and she completed her a psychiatry residency at the University of Utah School of Medicine in Salt Lake City, before returning to UK to complete training in Child and Adolescent Psychiatry. She's board certified by the American Board of Psychiatry and Neurology in Psychiatry, as well as Child and Adolescent Psychiatry.
Thank you.
So she's an underachiever. Thank you so much for being here.
Absolutely, it's a pleasure. And I was telling Melanie I have 4 kids of my own at home right now, and so let's send good vibes to my husband who is navigating the bedtime and homework routine, hopefully successfully. So thank you all for showing an interest and coming and listening to me speak for a little bit of time. I really do hope that you interject and ask questions. This can sometimes be a dry topic, talking about medication classes and some of the science behind our clinical trials. But I do think it's an important one, and obviously a lot of folks are here because they're interested to hear more about it. I want to primarily introduce you to a resource that I think is a good jumping off point for a lot of families who have children with autism when they're starting that conversation with their physician, be it a child psychiatrist who has experience with autism, or a pediatrician who sees fewer cases, or a developmental pediatrician. I think that this resource is something that I feel so strongly about that I teach all of my residents and fellows about it. I refer them to it, and I say, before you start seeing any patients in our clinic, you're going to have to understand this. And then we can talk about things a little bit more in depth and problem solve around a specific case. It was written for parents by child psychiatrists who are at a national level experts in the field of autism. And so what they have done is they've compiled all of the clinical studies that involve youth with autism and medications, particularly those medications that are targeting emotional and behavioral symptoms that can be associated with autism. Because before kind of compiling this information, a lot of what has been sometimes practiced is we've kind of, as child psychiatrists, as pediatricians, as developmental pediatricians, extrapolated a little bit from clinical studies of neurotypical kids who have anxiety, or neurotypical kids who also have ADHD. And what we're finding as we're studying this a little bit more rigorously is that you can't always do that. You need to take the whole child into account and what else is going on in that child's world. So I'm going to hand these out. Hopefully I have enough for everybody to go around, but if I don't, I know that Melanie can put a link up, I think, to this resource. That's okay.
Mel, send me that link and I'll put it on the website. Send me the link and I'll put it on the website.
Sure. Let them go.
So I kind of just want to familiarize you all with the information in this resource. It was published in 2016, so pretty recent publication. There are a couple of clinical trials with medications that have come out since this was published, and I'll try and remember to talk about those updates as we move through. Okay. So part of my job, I do run a developmental disorders clinic at the University of Kentucky. So I see individuals on the autism spectrum, individuals with intellectual disabilities, and individuals with genetic syndromes across the lifespan. And one of the things that I do in addition to running that clinic is working with the trainees, with the adult psychiatrists and the child and adolescent psychiatry fellows. So I'm used to giving them questions. That's why you guys have the first slide as a question. So, you don't have to answer this, but just in your mind, do you think that there are any prescription medications that have been demonstrated to improve the core symptoms of autism? It's a no. It's a false. So a lot of what we're going to be talking about today isn't necessarily medications that can improve social communication in an individual with autism, or can improve social emotional reciprocity. It's really going to be a focus on what are some of the other behavioral and emotional difficulties that that child may experience in the context of someone who is also on the autism spectrum. So I want to make sure that that's a clear distinction. None of these medications that we're going to talk about today are necessarily something that you would start after a new diagnosis, for instance, of autism. That's why you probably didn't hear about that in that first conversation.
So no magic pills.
No magic pill, but we will, I kind of want to whet your interest just so you hang in to the end. We'll talk about two areas of research that I'm really interested in, one of which, and I'm not, well, one of which is a phytonutrient or a plant chemical that does have some promising evidence with respect to improving some of those core symptoms of autism. So it's a promising first start. Definitely not, tested as much as I would like to see it tested, but I think it's a really exciting new avenue that we're starting to see being explored. Okay, so this is the medication guide. I think I mentioned that it was published just a couple years ago. When you take this home and try and start to digest it, there's several different sections within the guide. I think what's important is that a lot of what I'll talk about today are specific medications, but I don't want you to leave here thinking, I recommend medications for every child on the autism spectrum. That is the focus of today's talk, so I will be spending a lot of time about that, talking about that. But I really think that it's critically important for your work with a physician or a clinician when you have a concern about an emotional or a behavioral symptom, particularly if it's recently started or if it's changed in some way. You want to have a conversation about, well, why is this appearing now? What's going on in the environment? What's going on in this child's world to see why this is being presented at this time, and not necessarily jump to the use of the prescription of a medication. So I try and be very, very thoughtful about understanding why something is happening at this time and in this way. This guide is also going to spend, appropriately so, some time talking about what are the non-medication strategies to address some of these problems. So those are important. I think you've had other speakers certainly talk about some of the non-medication treatment strategies. We'll talk about the medication as a treatment tool. And then at the very end, what I like is, so many of the families that come into my clinic are very informed consumers of healthcare, and they like to see information. And so at the end of this guide, you're going to see a list of all the studies that involve youth with autism and these medications. And so if you're interested in a particular medication, your doctor mentions that particular medication, you can look at the end of this guide and see, well, what did that study really show? What percentage of those kids that were on that medication had, for instance, GI symptoms as an adverse effect. So you can get really specific about the information that you're learning from a reliable source. And then at the end, there's also a medication tracking form. So what you'll see as I talk is, a significant number of individuals on the autism spectrum are at some point prescribed a medication, oftentimes more than one medication, and sometimes at the same time and sometimes concurrently. And so what I think it would be helpful for a lot of folks to have is a way to track that information over time, because there are some physicians who don't see individuals over their lifetime, and so at 18 sometimes recommend seeing maybe an adult provider. And so you want to have that information and be able to carry that forward with you. So having a place to track that is, I think, important. Okay, so what are some of the reasons why a physician might consider prescribing a medication to an individual on the autism spectrum? Well, as I mentioned earlier, the core symptoms of autism aren't something that we're going to be really targeting with the medication. It's more likely going to be one of these items up here. So one of the things that I see in my clinic, anxiety is going to be at the top of the list. It's something that we need to really understand the limitations, I think, for medication use in this patient population. Mood instability, impulsivity, hyperactivity. We got a lot of kids now being diagnosed with both ADHD and autism. Used to be, a couple years ago, that psychiatrists said you could not diagnose both of those things in one individual. And so there's been a real shift in both diagnostic practices and then the clinical intervention. What do you do now that we are diagnosing both in the same child? We need to have, some understanding of what we can do to improve those symptoms. Sleep problems are a huge consideration. And then aggression, both self-directed and outwardly directed, is a concern for a lot of families. And I will say that by the time many families get to my clinic, oftentimes that's present, whether on a regular basis or intermittently. That is sometimes the reason why somebody might come into my office and talk with me. So these studies are a little bit dated. I should probably poll you guys about your top concerns. So this is as recent as I found, but I have a sitting audience that could maybe raise their hands and tell me what your top 3 concerns are. But at least one group of researchers found that among some of the challenges that their children face, frequent tantrums would be at the top of the list, aggression, and then hyperactivity. And then at some point in the course of their journey with their child with autism, almost 70% said that there was aggression at some point. That doesn't mean that all kids on the spectrum are aggressive, but that at some point they may have struggled with that. Anything else you would add to that list is maybe a top concern? Yeah.
I feel like I had read somewhere that aggression doesn't typically occur with autism. Does that ring a bell to you too? Have you read that in literature before?
Aggressive does not occur?
Yeah, that it's typically with other disorders.
So it can present with autism alone.
Yeah.
But maybe more so if there's a co-occurring ADHD diagnosis or another, what we would say a comorbidity, another problem coupled with that.
Okay, great.
Yeah, and I don't mean at all to characterize youth as being aggressive. This is, at some point,
I think it's
most all children, neurotypical children also experience periods of time where they're more aggressive. I have a 2.5-year-old, for instance, that is, at times hitting and, kicking his 1-year-old sister. So, yes. Okay. So again, when trying to understand what's going on here, why am I seeing in my child this marked increase in hyperactivity, or why all of a sudden am I seeing what appears to be anxiety or a lot of irritability. Maybe it was present to a small degree, but then you see a big spike. Okay, anytime you see a major change in the emotional and behavioral well-being of your child, you want to get really curious about what is driving that. Okay, and one of the things that I think is an asset to families of youth with autism, but also can be a challenge, is that there are so many different specialists and clinicians that can be involved in the care. What a speech therapist might potentially assess as being, maybe a communication difficulty, maybe a child psychiatrist sees in a different way. And so that's where it becomes really important to have, as much as you can, all of these different providers working together. So speech therapy working with the behavioral specialist, working with the primary care physician, working with the psychiatrist and the OT. That can sometimes be a challenge to get everybody on the same page, but that's certainly the goal. And there are some really lovely models of clinics that are medical and behavioral health homes where that's really the emphasis, is that everybody is a team and we're all going to provide our area of expertise in assessing a new emotional or behavioral health problem. And just my background is that I trained at the University of Utah, where there was something called a home clinic, which was just that type of a model. teams coming together at the beginning of a clinic day and talking about each case that they were going to see that day, and trying to thoughtfully think through what might be a challenge for an individual coming through the clinic. Okay, so lots of kids with autism are being prescribed medications. So 2/3 of kids at one point, or at least in the prior 3 years, are being prescribed medications. And I think this data is a little bit dated. But what's, I think, remarkable is 1 in 7 are on 3 or more medications. So, I think that, again, we want to get quality information and out to parents to be good sort of advocates for their child. There are 2 medications that have what's called an FDA approval for the treatment of youth with autism, and those are risperidone, or Risperdal, and aripiprazole, which is also a Bellefonte. Do most of you all know what FDA indications are? Okay, so what you'll hear me say is these 2 medications I've seen provide an immense amount of therapeutic benefit for a lot of individuals, but they're not necessarily the first medications that I will turn to, despite having this sort of stamp of approval from the FDA, and that's because they have some significant side effects that I think need to be considered very thoughtfully. Yep.
What kind of side effect?
So I can, sure. So they're in the class of something called a second generation antipsychotic. And those medications as a whole can cause significant weight gain. That would probably be one of the top concerns that you see really quickly. Increase in appetite. And it can predispose folks to something called metabolic syndrome. So blood sugar problems, insulin resistance that could lead to type 2 diabetes, and then cholesterol problems. So those would be kind of the main ones. You can also see sedation when folks first start those medications, so being tired and fatigued.
My son was on the second one for a short period, and it was short, very short, because his reaction was to walk around saying, "Thatcher, wake up." And he just kept saying it over and over and over again, like he thought he was asleep.
He felt sleepy and he was trying to express.
Yeah, it was awkward.
Yeah. So I don't want to, so yes, there are side effects. They're important to talk about and they're important to monitor for. Oftentimes, if that medication is going to be started, we want to get some baseline lab work, which can be a challenge for a lot of our patients, a lot of our kids. I mean, I don't like getting my blood drawn. And there are a lot of kids out there that don't like that. The nurse in the room is like shaking her head vigorously right now. So that can be a challenge because we want to make sure that in treating some of these severe emotional and behavioral symptoms, we don't cause, chronic medical problems as well. So it is something that it's a risk-benefit discussion that you want to have. Does that answer your question? Okay, so what's a medication trial? It's a little disheartening, I think, for families to hear from their physician, well, we're going to try this and see how he does or see how she does. We think it could be helpful for these symptoms, but we don't know for sure, and we kind of have to try it to see. I think as a parent, that would be incredibly difficult to hear. But nonetheless, we're approaching more personalized medicine, but we're not at the point where I can look at somebody's genetic information and say for sure that this is going to be an efficacious and well-tolerated medication. We're getting a little bit closer. I can talk about pharmacogenomic testing at the end if you'd like. But at the end of the day, a lot of times we have to try a medication and see how that individual responds to it. In general, I am a pretty conservative prescriber, but I think especially when working with individuals on the spectrum, you want to start at a very, very low dose and increase very slowly over time. So that would be one pearl that I adhere to. And then you want to give it sort of a an adequate trial, barring any major side effects. So, you want to stop a medication that's causing major problems right away. But in terms of the efficacy of a medication, a lot of times you have to give it, in some cases, weeks, close to a month, to see if that medication is going to be a good choice for your child. The caveat to that, or the exception, would be the stimulant medications. Those, you'll know very quickly if those medications are going to be efficacious or not. And so sometimes if I'm considering, a stimulant medication versus something else, I might try the stimulant first because I'll have a quick answer as to if that's going to be a helpful medication or not a helpful medication. And you're not kind of losing, a period of time where you're waiting for something like an SSRI medication to take effect, if that makes sense. And stop me if I'm saying anything that doesn't quite make sense. Okay, so we'll talk about aggression, tantrums, and irritability. So we mentioned earlier that the FDA gave the approval for aripiprazole and risperidone in the context of irritability and aggression for individuals with autism. And the reason for that is there have been multiple large, well-controlled studies in individuals to demonstrate that it is an effective way to reduce those symptoms. Again, therethere's that caveat that there are some pretty serious side effects that can arise that we need to watch out for. There's also a lot of evidence to support an older medicine called Haldol. So it's a medication that's been around for much longer than risperidol and aripiprazole, and it's something that I think is maybe underutilized at times, but has a long history of benefit for individuals with autism, targeting those irritability and aggression symptoms. With that medication, the side effect that we watch out for are movement disorders. So some individuals who are on that medication on high doses for long periods of time can have movements that are outside of their control. And historically, that symptom was thought to be irreversible. There's a new medication on the market that may help with that. But in general, we think of that as a long-standing side effect of Haldol that can arise. The next group of medications that can help with aggression and tantrums and irritability are called the alpha-2 agonists. So the third bullet point there. Those medications are blood pressure medicines. So that doesn't make a lot of sense why a blood pressure medicine can help with your child's irritability and aggression. But there have been a couple of controlled studies, and we also have found these medicines to be effective treatments for ADHD, for tic disorders, for insomnia. And so a lot of times if you have a child who's struggling with aggression, and they also have maybe tics that are impairing their quality of life, or they also have significant problems with sleep that's impairing their quality of life, then I will many times consider this as a first intervention before, again, trying the medications aripiprazole or risperidone. So again, less studies, but fewer side effects, and may also help with some other symptoms. So that's a nice option. Questions about those medicines? Yeah?
As you're talking about this medication, the earliest rule of thumb, what age is kind of are you, is it 5? I know that sometimes people ask about medications for the itty-bitties, like the 3 and 4-year-olds, but I know that there's a critical hesitation to do that. Like most of these medicines, better suited for a child at age 5 or 6.
Right. I would be very reluctant to use these before school age, personally. I know that there are some folks out there that feel a little bit more comfortable with it. I think that the sedation that you would see with all of these medications would be profound in a really young child. Again, I think there are extreme cases where I've seen other physicians do that, but I'm more comfortable with school age. It's a good question.
Does the sedation effect generally recede over time?
Yes, generally. But a lot of times it's hard to, well, it's hard to explain to an individual sometimes, why you're feeling more tired, and so, and it may be hard to overcome that. I would say, in general, clonidine is more sedating than guanfacine. But risperidone and Bellefonte are both probably equally sedating for most people.
Are these always given only one, not in combination with each other?
So, they are given in combination in certain cases.
So in a way, is it possible that increase irritability by making the child more tired, more sleepy?
I have seen that. You're right.
I'm using 2 of these products
Uh-huh.
together, and I still see some irritability.
Right.
And sometimes I wonder if it doesn't also come from that, not only, but maybe also.
I have seen clinically cases where I think that there's more like tearfulness and meltdowns because I'm feeling tired. When I'm tired, so my child didn't sleep last night. When I'm tired, I'm really prone to meltdowns, right? And so if this is making you feel sedated, that adverse side effect potentially could make irritability worse. You're absolutely right. And so what I sometimes see is, the reason why we're prescribing it is for irritability, but my starting dose didn't work, and so I keep on increasing the dose, and maybe that irritability actually gets worse because the sedation or fatigue gets worse. So it's sometimes hard to tease that apart.
Right.
Those are good questions. Okay, so yes, on this slide or the next.
It's related to
Yeah.
the combination question. If the child's on a combination, more than one medication, how do we as parents, or how would you recommend parents, because when you start layering multiple medications, you sometimes lose track of,
Absolutely.
we don't know, is it this one,
Right.
or this one causing this irritability, or the sedation, or, and
Right.
it just, how do we
That's a great question.
work with our doctor on that?
So I am a big proponent of making one change at a time. So there are certain cases where things are really, really bad, and sometimes I would think about starting 2 medicines at the same time, but it is very rare. If I'm going to start a medication, I'm going to start it, and I'm going to work with that medication to get feedback about what's happening from that one change in their medication regimen before adding something else in. This is where I think having an ABA get data and collect data before, during, and after a medication trial is incredibly powerful. There's something that I think I've seen quite a bit happen is that, maybe a family comes and sees me once a month, but the night before our appointment, there was something big that happened, maybe a really bad meltdown, the night before they come and see me. Well, the next morning, that's of course going to be what's on that person's mind when they come in. And so I might think, oh gosh, this isn't working, or this is making things worse. When what needed to happen maybe is some way of collecting information over the last 4 weeks. Does that make sense? Because it's human nature to just think back to, oh my gosh, that last night was horrible. And that's happened, and I get it. So that's where, if there is an ABA working with the family, oftentimes we'll have them come into the appointment and say, okay, we're going to start, this stimulant medication for hyperactivity and impulsivity. Can you please collect data on that for the next 4 weeks? And let's come back and look at that data when you return to the office. And
Maybe
then,
everyone knows, she's talking about
Oh, sorry.
applied behavior analyst, doing ABA therapy.
Yeah.
So.
no, thank you. So that's where I think you want to make one change at a time, and then be, even if you have just your calendar or your phone and you're making kind of notes daily, but trying to see if that intervention was helpful before making a second change, adding in something else. Or that makes sense. Self-injurious behavior. So, I have some folks in my clinic who struggle with this quite a bit. This is not, we're not talking about suicidal behavior when I talk about self-injuries. This is repetitive injury, usually to the head, banging your head, banging your hands on your body. That can be quite severe. The best evidence for this is that applied behavioral analysis, so the ABA intervention. But what could also be helpful is using those two medications, aripiprazole or risperidone, in conjunction with that intervention to reduce it. Okay, so I know a lot, or I've heard a lot of folks talking about maybe ADHD symptoms in their young person. So that's a pretty common concern. And like I mentioned before, it used to be that we as psychiatrists didn't really recognize that ADHD could occur in the context of autism. But now there's a real shift in understanding that those ADHD symptoms aren't sort of falling under the purvey of the autism diagnosis, but they're a co-occurring problem that can oftentimes benefit from medication treatment. What I will say is that compared to kids with ADHD without autism, the efficacy of our medicines aren't as great. Just too bad. So whereas maybe if I had a child in my office with ADHD and I were to prescribe the first line medication, so a stimulant medicine like methylphenidate or Ritalin, probably 80 to 90% would benefit significantly from that medication. A child with ADHD and autism might be closer to 50% would respond positively to that intervention. So the efficacy is a little bit less. And unfortunately, the side effects tend to be more common if there's ADHD and autism. So a lot of my patients may not just be able to tolerate that medication. That's where using a very, very small dose can be sometimes helpful. But knowing ahead of time that there might be some appetite suppression is very, very common, so getting hungry while the medicine's working. Sometimes you can have headaches, which is a concern if you have a kid who's nonverbal and can't express that. I see that sometimes I know that there might be a problem with headaches because of more of that self-injurious behavior hitting the head as potentially being a sign that they're experiencing a headache with a stimulant medication. Insomnia can happen and sometimes irritability. So I'm painting a very negative picture about some of these medications. I have seen a lot of patients that benefit from them. So I think working with somebody that's used to using these medications in this way is helpful. And I get feedback oftentimes from the behavioral specialist or from the speech therapist or from the occupational therapist saying, gosh, before we use this medication, the therapeutic window that I had with your child was very small. But now we're able to maybe be on task and deliver that therapy for a longer period of time. And so that's one way that I see these medications being a powerful tool. A couple of the ADHD medications that are also helpful at times are something called atomoxetine or Strattera. So that's a medication that is about as effective in these kids as methylphenidate. The sort of downside to that one is it is one that you really have to take daily and build up in the system over over a period of weeks to see the benefit of it. And in the clinical trial, you really, to see the benefit for the ADHD symptoms, have to get to a specific target dose based on their weight. And a lot of times I think physicians, may not push the dose to that higher dose range to see if it's going to be efficacious or not. And I can understand that because there sometimes is nausea, sometimes decreased appetite, sometimes drowsiness with that medication too. Guanfacine is another medication that we mentioned before as potentially helping with tics, sometimes with insomnia, and it can also help with ADHD symptoms, so that's also a choice at times. So there's a lot of options available that have been studied. We just temper our discussions with understanding that it might not be quite as effective as, if you had a sibling with ADHD that was doing great on one of these medicines, it may not be quite as effective for the child with autism and ADHD. Questions about this? Okay. So repetitive behaviors, because of some of the overlap with OCD, with repetitive motor movements that we can see in autism, so repetitive hand flapping or rapping or rocking behavior, repeating a phrase over and over and over again. Folks in the fields thought, this looks somewhat similar to individuals who have obsessive compulsive disorder and they are repeating a compulsive behavior over and over and have difficulty stopping that. So the medications that have been found to be helpful for OCD were tried in this patient population and unfortunately really found to not have a big benefit. So I do see a lot of individuals who are tried on medicines that are used oftentimes for OCD, and by and large they haven't been terribly helpful for that. Okay, anxiety. I know that this was an interest of some of you guys in the room. Unfortunately, there are not a lot of good studies to say that any of our medications have been overwhelmingly helpful for anxiety and autism. The highest evidence that we have to treat anxiety would be cognitive behavioral therapy that's been modified for the person with autism. So we have a psychologist at UK that I worked with who presented here before, Angela Combs, and she is delivering this intervention for a lot of my patients who have anxiety and are on the spectrum. That doesn't mean that I haven't seen medications tried for this. Some patients, some individuals do benefit, but I would say by and large, if you do try this type of a medication, so anxiety medicines like Prozac or Zoloft or Paxil, Celexa, Lexapro, those medicines are oftentimes used to treat depression and anxiety. I oftentimes see patients started on these, and when it doesn't work, they kind of, the dose gets kind of increased and increased and increased and increased. And I think in some instances that worsens symptoms because of a side effect called behavioral activation that can happen with this medicine. So behavioral activation would be appearing more irritated, appearing to be pacing or increased motor movements, feeling or appearing to look restless. And so a lot of times I think we get in a cycle of, well, that looks like maybe anxiety, so I'm going to increase the anxiety medicine, whereas it might be that they're experiencing a side effect from that medication, not a benefit from it, if that makes sense. So the big leader in anxiety and autism is a woman named Roma Vasa, and she has published a really great overview for pediatricians to take a look at in treating individuals with autism and anxiety. And she provides some guidelines. If you're going to try one of these medicines, you're really going to start at a quarter of the starting dose that you otherwise would if you think about it. And if you're going to try it, maybe try a medicine that is stays around in the body for a short amount of time rather than a really long amount of time. She also talks about if there's a big life event in your family, a wedding or something really major that you think could be anxiety provoking for your child, there might be a role for a one-time use of something like Ativan, a benzodiazepine. So it wouldn't be something that you would want your child on all the time, but there's something that really is important in the life of the family and you want to try and reduce anxiety for a one-time event. That might be something to try. Yeah.
What was her name again?
Roma Vasa, and she's at Kennedy Krieger. Roma
Yeah.
Vasa.
Just like it sounds. Okay, it was just so odd. I thought.
Lovely
okay.
lady, yeah.
Okay.
And a lot of this is straight from her paper and some of the talks that she's given. So thinking about other ways to reduce anxiety in your youth with autism. I'm sorry, do you guys want to write that down?
While you're doing that, I'll ask you a question. I believe I've understood in the past that a lot of the ADHD drugs will have a different effect in a younger population than an older population. Is that right?
I wouldn't say
Adults, as compared to children.
well, the dosing is weight-based and may change over time. But I don't necessarily see a significant difference, as long as you're accounting for the weight-based dosing, significant changes in the response to it. So insomnia, gosh, it's a problem for a lot of folks. One of the sleep specialists at UK gives me some of his pearls specific to autism and insomnia. And really the thing that's been shown to be most beneficial is melatonin, which I think a lot of people have tried, and it's not a wonder, it's not a cure-all for everybody, but is really the only thing that's been shown in autism to improve insomnia. Keeping the room really, really cold has been found to be helpful. 68 degrees seemed really cold to me, but we're talking sometimes even lower than that. And then, some of the sleep hygiene pearls that, everybody is probably telling you, which is, no electronics in the bedroom, which is a hard one, consistency with the bedtime, having a specific routine, those kinds of things can be helpful.
We have a script.
You do?
Yeah, we have to say it every night. If we don't, our son doesn't go to sleep.
So that's what you do?
Yeah.
That's your routine?
And we left him with my mother-in-law when he was really little, left her the script. And she thought it was silly. And we called to check on him. And she said, he won't go to sleep. And my husband said, Mom, did you read the script? And she said, well, no. He said, read the script. We're not telling you this because we want to mess with your life. We're telling this for your benefit.
Right.
He went right to sleep.
Yeah.
Have they found any particular dosings or types of melatonin forms? Because there's different forms now, that kind of thing that is of benefit. Like, are they supposed to be getting double what normal people get? That kind of stuff.
Oh, and double what normal people?
Yeah,
No, I would not.
Dose.
Right.
Yeah.
No, I would use no more than 10 milligrams. Start at the lowest possible dose, which is 1. What you typically find is just the immediate release over the counter, and that can be helpful for falling asleep. But sometimes kids wake up in the middle of the night, and that's where a sustained release form of melatonin might be more helpful. Sometimes you have to look at the packaging or talk to the pharmacist to find the sustained release form of it. So pica, this is not a very common, it can happen, but pica is eating substances of no nutritional value, and sometimes you can see that in kids with autism. No medications that have been shown to be helpful for this. ABA, applied behavioral analysis, is been the most evidence-based thing to help. But your physician might look for any nutritional deficiencies that might be contributing or playing a role in that behavior. Social communication, there was one single study suggesting that methylphenidate, so that ADHD medicine, may help improve social communication. It's thought that potentially a more focused child that was really what the effect of communication was attributed to, rather than, again, the methylphenidate impacting that core symptom of autism, if that makes sense. Okay, so weight gain, I think I talked about at the beginning as being a really concerning side effect of aripiprazole and risperidone. So one of the things that I was really excited to see was this paper that came out a couple years ago that showed that there was something we could do about it, because there are kids that for a period of time, because of significant safety problems, may need to be on one of those medicines. And like I said, I really don't like causing a medical problem to try and treat some of these behavioral and emotional difficulties. So metformin was studied in youth with autism who had gained weight on one of those medicines. And what they demonstrated in this trial was that, number one, the kids in general were able to take the metformin without having so many side effects that they had to stop it. And it was able to decrease the weight gain that had occurred. Not necessarily completely reverse it, but not have it continue to escalate and escalate, which is something that can happen with individuals. So that was a real, I think this was for me personally, I was very excited when I saw this study come out. It doesn't mean that I, disregard weight gain. I'm like, oh, metformin for everybody. But, it is another tool that now I have that I didn't have a couple years ago. So,
what level would you recommend metformin?
So it depends on the age and the weight of the child, and also their tolerance, because there are sometimes diarrhea and that can happen with it. So we start pretty low, and the target dose I believe was, I don't want to tell you the wrong dose, but if you're over 70 kilos, I think it was 1,500 total daily dosing per day. But this was a nice study.
Because with risperidone in particular, that weight gain is so rapid.
Yeah.
You need to balance it out with some kind of, not just exercise, not enough, some kind of other medication treatment. And then what that does is interfere with appetite and cause gastrointestinal distress. So it has so many more complications than what the parent is trying to do.
What they haven't studied, which I'd be interested in, is starting the metformin with the risperidone at the same time to see if you can prevent the weight gain altogether. That would be a study that I'd be interested in seeing, but isn't out there that I know of right now. So. Other questions? I'm just going to kind of talk briefly, if I haven't overloaded you guys, about a couple things in the works. Yeah. Gynecomastia, yes. Yeah.
Does that decrease that?
No, it doesn't target that. So what Melanie is talking about is risperidol can also increase levels of prolactin, which is a hormone that can impact a lot of different functions, but can cause breast tissue to develop in very rare cases. So I would say that this is something that you see on commercials, but clinically, I do not see this very often at all. But it is a concern, and it does happen. So the neat thing about the two medication options that I've talked about is that Bellefonte does not have that side effect, and it can actually reduce the prolactin levels in somebody who has had elevation with risperidone. So when Abilify went generic, that was it. So it used to be that risperidone was generic, aripiprazole was $700 to $800 per month, and so we went with risperidone. But now aripiprazole is generic, and so if that's at all a concern for an individual, it makes a lot of sense to switch to that medication.
Again, it's not better in the beginning, right? But rather than in the middle of someone who already has diagnosed.
We do not routinely recommend checking prolactin levels because, by and large, you will have an elevation, but it's not always clinically significant, meaning they don't always have symptoms related to the elevation of prolactin. And so I've had a couple of cases where it was sort of checked, the prolactin level, and it was found to be high, and somebody was immediately switched to something else, and there was a significant destabilization in that individual. I mean, there was major problems rapidly stopping that medication. And so, you know, typically if you see signs or symptoms, you test then, but it's not necessarily common practice to check those levels intermittently, the way that we would with the blood sugar and the cholesterol profiles. Okay. So, you guys need a break, or this is just, I was just going to tell you about, you know, things that I've been reading about that I think are interesting and things to look out for down the road. So there's new technology. So this is the eye gaze tracking. So when you had that question about, you know, when you start a medicine, or when you have two medicines, how can you tell what's what? And I was saying, you know, it's really helpful to have a behavioral specialist collect data over time to see if whatever we were using the medication for was actually working. Well, that takes time. That takes a clinician collecting the data, reviewing it. What's really interesting and promising, I think, is this technology of looking at eye tracking. So individuals on the spectrum, if they were to be viewing a video of, let's just say, a playground scene, what their eye and where their gaze on that screen while watching that video, where they're spending their time looking is going to be very different from a neurotypical kid. And there have been a lot of studies, 122 at last count, investigating those differences and collecting that data and coming up with an algorithm to separate kids on the spectrum from neurotypical individuals. So there are different kind of video scenarios now that are out there, different measures in terms of are we looking at how long that they look at, for instance, a face versus an extraneous, you know, something that was spinning in the environment. And with this recent study that was published in November, what the researchers found is that we're getting really close to being able to have individuals watch this video, track where their eyes move as they're watching it, and separate if that individual is likely to have autism or not, which is huge, right? If we can find a streamlined mechanism to diagnose in an objective way that does not require sedation, that can be less than 5 minutes, can be used across ages and cognition, so, you know, all levels of intelligence, all developmental stages. Fairly inexpensive, and this is at the beginning of this technology. It should probably go cheaper, I would imagine. Wow, that's pretty huge. The other benefit to this is, so it has diagnostic implications, but then intervention implications. So let's say you administer a treatment to an individual. You can do this before and after, and see if you're making a clinically significant improvement with whatever, if it's a medication, if it's a therapy, whatever the intervention is. This has the potential to, I think, fast track clinical improvement. It also has research implications. I mean, there's just so many exciting possibilities with this technology. So I just wanted to. So this study, so these studies on eye tracking have been going on. I think I probably first heard about it maybe 5 years ago, but it's sort of reaching this kind of climax. And this paper came out in November in a major, so you know, the major journal for my profession published this in November. So this is new, but again, I think it's a way to take that bias out of things, which I love.
Will it replace the chat test?
So it could, I mean,
Wow, I've
Yeah.
never heard of this.
so it really can, I think, has a lot of potential. So this is kind of the setup. It's not being used in clinics that I know of now, but again, I think this is coming in the pipeline. So, you know, I just heard about it.
So would it also, I mean, the chat test is kind of a screener, would it replace the more in-depth evaluations?
Potentially, yes.
Wow.
Yep.
Are you familiar, this is kind of on the topic, but off the topic. I saw Temple Grandin like a few years ago, and one of the things that she showed, I don't know if this, you know, this is just something that she presented. I don't know if this goes across the board with autism or not, but she presented like the letter S, and it was wrote with small F's. Have you ever seen that? And she said
What do you
that
see?
like people with autism, if you present it to someone with autism, would see the F's rather than the S. Right. Yeah. So it's just something that.
Right.
Yeah.
I think it gets to that kind of the difference in kind of where you're focusing in on in any sort of stimulus that's presented to you. There are differences, and so this is trying to quantify that in a way that I think can be pretty helpful. So this, I began kind of the talk saying, you know, there's no prescribed medications that have been demonstrated to impact core symptoms of autism. This is a study that is a couple years old, but not too many people are kind of talking about it as much as I would have maybe imagined. But sulforaphane is what's called a phytonutrient. So it's a component found in cruciferous vegetables. You guys are going to think I'm a little bit of a hippie, but this is so exciting to me as well. So cruciferous vegetables produce this chemical. And what I think is really interesting about this is, you know, the medications that we just ran through, they treat, again, sort of the emotional and behavioral symptoms that can accompany autism. What this chemical is hypothesized to do is reverse some of the biochemical changes that are present in individuals with autism as compared to folks without autism. So it's not kind of treating a symptom, but trying to treat the pathology that's driving the symptoms, if that makes sense. And so this study was done in association with Mass General and Harvard. So this is really interesting work that they're doing, and it was a robust study in terms of it's placebo-controlled, it was double-blind, it was randomized. It was small. I think the total number was only 27, individuals. But again, this is a good start. And what they demonstrated was that there was an improvement when these young men took this broccoli extract supplement
So they
daily.
extract it.
So they extract it, and they took it based on their weight. So it was like 1 capsule, 2 capsules, or 3 capsules based on their weight, daily for 18 weeks. And they did show that social responsiveness or social reciprocity was improved in a higher number of the kids who had the intervention versus the placebo. Abnormal behaviors, competitive, restricted behaviors were improved, and verbal communication was improved. So I thought, gosh, this is a really interesting study. And what I also thought was interesting is they followed the kids up 4 weeks after the supplement was stopped, and the benefits were reversed. So pretty interesting.
There was one interesting side effect of that study.
Weight gain.
Flatulence.
We actually tried this, and I was growing sprouts in
Yeah.
jars.
Like this.
everywhere.
This is at my
Yes.
house. Yeah.
That was a part of my life for a few months,
Yeah.
and I could not get him to eat them.
Yeah.
I was like trying to grind them up and smush them, and we just had so much trouble trying to get him to eat anything, and then you'd ruin chocolate pudding and never be able to eat chocolate pudding again.
That's a side effect, ruining chocolate pudding.
Yeah.
Not okay.
Yeah, because anything like
Yeah.
that ruined it for him,
Yeah.
and he'd never eat spaghetti. I was like,
Yeah.
I hate
So
to
that's-
ruin what
yes.
little food he would eat.
So hopefully, if this continues to be studied and there are trials that continue to show benefit, my hope is that we'll have an extract that you can
Yeah, because right
reliably
now,
buy
this
over the
is how
counter.
you can buy
'Cause
this
this
on
is
Amazon.
Yeah, this is what we do. And we blend it up in smoothies at home, but it's not for everyone.
But it's hard to get blended fine? Is that-
It's just real strong. It's like
It
a
tastes-
broccoli.
It tastes, I think it tastes like alfalfa sprouts.
Yeah, it's just really, really strong, especially for your kids that have all those sensory issues.
Yeah. Oh yeah, absolutely.
This disguise is pasta sauce.
What's that?
The best disguise for replacement for is pasta sauce.
Yeah, and I try to sneak things into pasta hot, and they'll see something that looks like a spice and they look at it. My child is like really
Yeah.
small, and I can't even get him to eat chocolate. Like he's so small and just so hard to feed. Right now we're on goldfish and raisins and marshmallows. Like that's his diet. So we're assuming protein powder in his milk because he's not eating. Like I'm waiting for you to talk to me about some
Magic
marijuana.
I was not gonna go there. You can try, but I'm not gonna hear that. Any questions? Yeah.
Yes, would it take a lot of it to maybe you have some experience?
So 50 micromoles up to 150 micromoles is the dose that they studied. So there are companies that will sell you broccoli sprout extract. I just don't know how reliable they are at this point.
We don't know that they're actually putting in it.
We don't know, it's not FDA regulated, we don't know what's actually in there, what contaminants might be in there, which is why I like the idea of, if you're able to, food as medicine, speaking to your
So practically, because I
Yeah.
have this in my kitchen,
yeah.
and I make puree every day,
Mhm.
can I just mix this in my puree and
I would blend it and put it in your puree. Because, the thing, so you're right, maybe gassy as a side effect, and then there was like a 4-pound weight difference, so possible weight gain. But sulforaphane as a supplement is being studied in a whole range of medical conditions, and it's been shown to increase all-cause mortality, meaning there's some just benefit to just longevity with this phytonutrient. And so I don't see a ton of downside if you're able to incorporate it into your diet. Notwithstanding the autism symptoms, it's a healthy thing to add to your puree if you're able to tolerate it.
not me,
In the study, it was every day for 18 weeks. And they didn't start to see a difference until week 4.
And there are cookbooks that you've probably already tried, like called Deceptively Delicious is one, which is all about learning the heck out of foods so that you kind of that one is by Jessica Simon. Deceptively Delicious. It's not the only one, there are competitors.
Thanks, you all. Fun to
Thank
work
you.
with.
I love it.